Session of free papers on diabetic retinopathy and medical retina. Dr. Lubhani Jain, who was supposed to present in the second slot, is requested for a change. I would like to request her to please speak to us on diagnostic accuracy of an online artificial intelligence algorithm for diabetic retinopathy. Dr. Lubhani.
Thank you so much for accepting that change, sir. And at the outset, I'd like to thank AIOS for the opportunity. So I'm going to present our work on the diagnostic accuracy of an offline artificial intelligence algorithm for diabetic retinopathy. I have no financial disclosures. So diabetic retinopathy is a major cause of preventable blindness in the working age group, and it is asymptomatic in the early stages, as we all know. The traditional desktop fundus cameras are expensive and they need training for the technicians, while smartphone-based fundus cameras are low cost and they're easy to use with everybody having a smartphone these days. So in rural India, access to stable internet connection is also a problem, which brings us to the need of having a easy-to-use smartphone-based fundus camera for screening of diabetic retinopathy. So the aim of the study was to assess the diagnostic accuracy of an offline smartphone-based artificial intelligence algorithm to detect referable diabetic retinopathy compared to grading by ophthalmologists. It was a retrospective study where type 2 diabetics above 35 years of age were included. We collected the preliminary data such as the age, gender, duration since the diabetes onset, and the eyes were dilated using a single drop of tropicamide phenylephrine eye drops 1%, which has been found to cause a minimal risk of angle closure glaucoma. A single drop was required because the minimum pupil size was 3 mm to capture a good quality image, and the Asian pupil size has been found to be 2 mm. So to compensate for that, a single drop was put. Remedio non-mydriatic fundus on phone 10 was used as the imaging device. It is a portable smartphone-based non-mydriatic retinal imaging system, and a technician was trained to capture the images. The device had an inbuilt offline AI algorithm which signaled for poor quality images, which prompted the technician to continue to take images until a good quality image was obtained. 3 fundus photographs were taken in each eye, one centered at the macula, one on the nasal field, and one in the superotemporal area. These 3 fields were found to have 92% sensitivity for detecting any retinopathy and 86% sensitivity for detecting PDR, compared to all 7 standard ETDRS fields. So the images were diagnosed by with diabetic retinopathy or retinal disorders by 3 ophthalmologists independently, in a masked manner, which served as the ground truth, and a patient-wise diagnosis was based on a consensus grading of the worst eye. This grading was done as per ETDRS, and a patient whose images of one or both eyes were considered ungradable were excluded from the AI analysis. So the images were then subjected to an auto-imitated analysis by Meteor's AI, which is again inbuilt in the device. It's a proprietary offline AI which is used to identify referable DR, which was classified as moderate NPDR or higher stages. And it is a binary type AI where only no DR or referable DR can be detected, but the grades of diabetic retinopathy cannot be further classified. The mechanism relies on 2 convolutional neural networks. Initially, the black border of the image is cropped by an algorithm, and then it is converted into a standardized imaged size. One of the 2 convolutional neural networks also is empirically optimized for contrast enhancement, where the DR lesions are made to stand out on the input images. The sensitivity and specificity statistics were computed for both NEDR as well as referable DR, and of course the ophthalmologist grading was taken as the ground truth. So of the 254 patients imaged, only 225 met the requirements for grading, and they were included. Of this, we found that there was 100% sensitivity and a 69.19% specificity for referable DR. There was a 72.72% sensitivity and 100% specificity for no DR. On excluding the 53 non-DR pathologies falsely identified as RDR by AI, the sensitivity remained 100% for RDR, but it increased to 96.97% for RDR, and there was 100% sensitivity and specificity for excluding DR. So, as we know, healthcare access in rural areas is poor, and this is where a majority of the Indian population resides, which is the reason for the need of an offline AI. The sensitivity of referable DR was 100%, similar to those found in previous studies. But there was an increase in the specificity of the AI algorithm from 69.19% to 96.97% when the 53 cases of non-DR pathologies were omitted from the analysis. So this is because the AI algorithm is not trained to decide whether it is a non-DR pathology, and these cases are simply read as referable DR by the AI. This loss in specificity was neither due to image artifacts, nor was it due to an overestimation of cases of mild NPDR as cases of RDR, and ultimately even these cases do need an ophthalmologist referral. So the limitations of the study include the small sample size as well as the inability to test the sensitivity and specificity of individual diabetic retinopathy grades by this algorithm. However, it does highlight the usefulness of AI in diabetic retinopathy screening as an instant and accessible grading tool which can be used in rural India. Thank you.
You think that this RRD,
Yes, sir. Referable DR. Yes, sir.
is it a good term to use, and how will it be useful?
So since we are using this as a screening tool where it's mainly led by technicians, it is preferable to start referring from an earlier stage of moderate NPDR. And I think it is quite a useful tool, sir, because amongst 100 patients of diabetes that we screen, about 20 of them would have some form of DR. So even if we can screen out the 80, at least we're referring only the remaining 20 to a nearer vision center or a ophthal clinic. So it will help reduce the burden.
I thought by doing this screening business and handing over the task to a technician
Yes.
and doing it on AI basis, the important thing is that we are covering larger population,
True.
but which is not really empowered or trained to
Correct.
diagnose.
Correct.
But we are empowering them through AI.
Correct.
So that is where the role is, because
Right.
not every case of DR may be referred,
True.
but of course RRD may be.
True. True.
I have one question that
Yes, sir.
you do not have a control group for your study.
That's true, sir. So we didn't have a control group because this was done in a retrospective manner, and then we used the ophthalmologist grading as the ground truth to compare and validate the AI.
But that does not rule out the bias as well.
That's true, sir. So the AI has already been validated. We just went a step ahead with taking a larger sample size to do the validation at our end. But yes, you're right. I think the limitation of the study would also be that.
You are solely dependent upon the AI.
Yes.
It's
Yes.
and the second question which I wanted to ask is why only 3 photographs that you chose to click?
So this was just for an ease of a functionality choice, because the technicians would, in a 3 mm pupil size, for them to be able to capture clearer images and to fasten the process.
No, would that minimize your sensitivity in that?
So as per the previous studies, it doesn't, sir. I just shared that it has an equivalent sensitivity to 7 ETDRS images as per the previous data, which is why it was a good compromise to make for fastening the process.
Actually, you based it on the in literature reports which indicated that these 3 areas were the maximum sensitivity.
Maximum sensitivity.
And was equivalent to having
The
7
7.
ETDRs.
Yes.
That should
Yes.
be the answer.
Yes.
Thank you.
What is the qualification of technicians?
So the technicians are actually 12th pass graduates who have an experience with using the smartphone. That was the criteria that we gave out because we wanted this model to be scalable in the long run. So we wanted to test whether it is scalable, which was possible only when we had technicians who were easy to find in rural areas.
No. I think you should have, whether you have done it or not, but you should have mentioned that these people were trained for a week to take fundus
Correct.
pictures with this.
So, Yes, so they were trained, and in fact they are technicians who were working in our hospital setup for fundus photography, perimetry, and the routine tests, OCT capturing. They were the ones who we had deployed to do the study.
Fine. Thank you.
Thank you. Thank you.
Ashok Kumar. Yeah. Ji? He'll be presenting half fluence photodynamic therapy in peripapillary circumscribed choroidal hemangiomas. Your time is 6 minutes, and discussion time is 2 minutes. Okay.
A very good afternoon and warm regards, everyone. I'll be presenting on.
And we have to. Somebody has to click the timer.
Very good afternoon and warm regards, everyone. I'll be presenting on half fluence photodynamic therapy for peripapillary circumscribed choroidal hemangiomas. Choroidal hemangiomas are very uncommon benign vascular tumor of the choroid. They can be either diffuse or circumscribed. The circumscribed choroidal hemangiomas, or CCH, are typically unilateral. They are round and well circumscribed, orange reddish in color, and mainly found in the posterior pole of the fundus. That's why they become a little more symptomatic as compared to the diffuse one. On FFA, they typically show a very bright hyperfluorescence with rapid early filling of the vessels, and OCT shows a typical dome-shaped contour of the retina with absence of choriocapillaris compression. These circumscribed choroidal hemangiomas usually present with a very significant visual impairment because of presence of macular edema as well as serous retinal detachment. And if chronicity per se persists, then they lead to photoreceptor loss, which can be avoided if treated early. The different treatment options which are available with us include laser photocoagulations, cryotherapy, proton oblique external beam radiotherapy. TTT has also been tried, but off late photodynamic therapy has become treatment of choice for these patients. But all these treatment options have potential complications in form of choroidal atrophy, optic nerve damage, which is more common in circumscribed peripapillary hemangiomas, where you need to treat this patient closer to the optic nerve, and obviously photoreceptor loss. So targeting a peripapillary hemangioma with the full fluence or bolus PDT can lead to inadvertent damage to the vascular supply of optic nerve head and further optic atrophy. On the other hand, if we use half fluence PDT, which has been tried in other choroidal pathologies like IPCB as well as CSCR, has shown that reduced complication as well as increased or comparable efficacy in these patients, as reported by Elkin and Bong et al. In their studies. So when we target a abnormal vascular tissue within choroid, even with a low or a half fluence setting, it becomes a logical and safe option. So with this background in mind, we planned this study to evaluate the safety and efficacy of half fluence photodynamic therapy for treatment of this symptomatic circumscribed choroidal hemangiomas. So it was basically a prospective interventional study carried out at Tertiary Care Referral Hospital of Armed Forces in North India. All patients who had symptomatic peripapillary circumscribed hemangiomas more than 18 years of age and presented between June 2017 to May 2020 were included in this study group, and all patients who had a previous history of treatment in form of laser, anti-VEGF injections or PDT for hemangioma or any other concurrent retinal disease was excluded. All patients underwent a comprehensive ocular examination in form of best corrected visual acuity, fundus photos, FFA oblique ICG. SDOCT was done for measuring the central macular thickness and RNFL thickness. USG B scan was done to to confirm the diagnosis, and visual evoked potential was done at the baseline as well as repeated at 6 months post-treatment. Informed consent was obtained from all the patients. So all these patients underwent half fluence PDT under the standard setting, except that laser power of 20 millijoule per centimeter square was used in place of 50 millijoule, which we use in a standard setting. Laser spots varied according to lesion size, and a safety margin of almost 200 micrometer of treatment was kept from the optic nerve head. Retreatment was given in only those patients where if fluid persisted at 12 weeks post first treatment. And all these tests were repeated at baseline, 4 weeks, 12 weeks, and 24 weeks. Statistical analysis were carried out by using ANOVA as well as pair t tests. During the study period, we had 13 patients which were treated with half-luminous PDT. Of them, only 11 completed the required follow-up. Average age was almost around 54 plus minus 9 years. There was a male preponderance. Out of the 11 patients, 7 were males, and all patients were symptomatic with diminution of vision and had macular serous detachments. So once we treated them, we had a structural as well as functional improvement in 9 patients. That was almost 81% after one sitting of PDT with half luminance, and all patients, or 100% patient, had a functional as well as structural improvement after one additional sitting in 2 patients. And vascular visual acuity improved significantly from baseline at 4 weeks, at 12 weeks, as well as 24 weeks in these patients. 2 patients who had a minimal reduction in subretinal fluid were repeated with a single session of half-luminance PDT at 12 weeks. And central macular thickness also reduced significantly from the baseline at 4 weeks, 12 weeks, as well as 24 weeks. No adverse effects or complication of treatments were noted. BAP measurements didn't show any increase in P100 latency or decrease in amplitude. No significant change in RNFL thickness was seen pre and post treatment. So this is an image of one of our patients having a large peripapillary circumscribed choroidal hemangioma, which was confirmed on a ultrasound B scan, had a large intraretinal as well as subretinal presence of fluid, and RNFL thickness was normal before treatment. And this is what we could achieve at 24 weeks. We can see this shrunken choroidal hemangioma and total disappearance of intraretinal as well as subretinal fluid in this patient, and RNFL thickness was same. This is a demographic and clinical profile showing 2 patients required a half-luminance PDT, which was repeated at 12 weeks. So PDT is a treatment of choice for choroidal hemangioma as it strictly targets abnormal choroidal vessels without affecting overlying neurosensory retina. Is indicated in symptomatic patients which have macular edema or subretinal fluid. Various protocols has been used, and almost all protocols have been effective. But these standard protocols have a lot of procedure-related complication like damage to optic disc vasculature, which is more common with the peripapillary circumscribed choroidal hemangiomas, choroidal atrophy, treatment failure, perifoveal hemorrhage, as well as choroidal effusion. So our study was the first attempt at evaluating safety and efficacy of half-luminance PDT, and visual improvement in our study was comparable with what was reported by Robertson et al. Using a bolus or full dose PDT. Only 2 patients required a retreatment. And one of the positive factors of our study was that a new parameter in form of RNFL thickness was used for the first time to establish the safety in these patients. Our study had certain limitations, small number of patients, no control group, and even the follow-up was smaller for only 6 months, because up to 35% recurrences have been reported on a long-term follow-up. But the strength of our study was the new variable of RNFL thickness, which was used to validate the efficacy. So to conclude, half-luminance PDT can be a safe and effective treatment for symptomatic peripapillary hemangiomas. Both anatomical as well as structural improvement has been noted with no observable complication, but we recommend that large prospective comparative studies would be required for a more significant evidence to validate this protocol. Thank you.
Study was done only in the peripapillary.
So 13 with peripapillary choroidal hemangiomas only. Sir.
Okay, only.
Out of them, only 11 completed the 6 months follow-up. 2 were lost to follow-ups. So that's why only 11.
And how many repeat?
So 2 repeat. We required only
twice.
Repeat PDT in 2 patients.
Okay, only.
You think the parameters should have been changed for the repeat PDT?
So the basic cause, what we felt of the retreatment was because these hemangiomas were large in size, more than 5,000 micrometer. So we could have gone with the addition of anti-VEGF or something like that along with the PDT. That would have been
There was a catch in this question. I think you should have titrated it with the amount of fluid which was there. It would have interfered with the PDT treatment, even if it was half-luminance. In the sense that higher the fluid, larger the fluid, those patients who had more fluid must have needed the
little higher parts, even little higher fluence.
Or repeat.
Repeats.
How you have spared 200 microns from the optic, no?
So it was just
No,
We tried not to go as much closer to the optic nerve head so that at least optic vasculature and all those things.
I was just wondering that you said that RNFL was preserved in half fluence PDT. Do you have any idea how was it with full dose therapy?
So we don't have.
Generally, that won't affect the RNFL as well,
Sir.
because it's the choroid which gets affected by the laser that you do,
Sir.
the PDT.
I thought you should have brought out in literature some report of damage to the optic nerve head and reduction in the RNFL thickness with full fluence
So we searched.
PDT. The reason is
Sir.
it doesn't seem logical that there would be damage to any of these
Sir.
structures. I appreciate you are having done this, good thing,
Sir.
but for the purpose of,
So we did a comprehensive search, but we couldn't find anything.
perhaps next
which
time you can
actually-
tell us what happened to those patients after 6 months. But it's a good initiative.
Good,
Thank you.
but it's appreciable that you have got so many peripapillary.
Because the study
coronary
was carried out at only
center.
Referral Hospital of Armed Forces, so that's why we had a
Yeah.
referral from
All
all over the
India-
country.
all
That's why
Yeah.
we could get so many patients.
Good
Otherwise
study.
It's difficult to get so many patients.
Okay, thank you very much.
Thank you.
Thank you.
कोणी बोलायचं?
Next is Siddharthan, Mechano transduction, a paradigm shift in pathogenesis of age-related macular degeneration.
Siddharthan is here, no?
Yeah, Siddharthan is there.
Of a study on the Mechano transduction, a paradigm shift in the pathogenesis of age-related macular degeneration. So what is Mechano transduction? So it is the phenomenon by which mechanical signals are converted into biochemical signals by the cells. So one analogy which helped me to better understand this phenomenon is the microphone. So here mechanical signals or sound waves are converted into electrical signals, where in Mechano transduction cells convert them into biochemical responses. So a dysregulated Mechano transduction has been implicated in several diseases, dysregulated responses to flow in atherosclerosis, to stretch in cardiac hypertrophy, and confluence in cancers. Similarly, the cells also respond to changes in the mechanical properties of the substratum on which they sit. So why is this phenomenon even relevant in AMD? We know that the RP-Brooks membrane interface is the focal point of several hallmark changes which happen in AMD. So the RP which lies on the basement membrane will come to lie on these deposits in macular degeneration. So our hypothesis was to study the effect of mechanical changes exerted by these sub-RP deposits on RP homeostasis and in AMD. So again, to understand how we went about answering this question, I'd like to come back to the analogy of the microphone. So there's the input, which is the mechanical or the sound waves, and the output. But then there is the crucial role played by the microphone, which has a sensor which senses the changes in the sound waves, and then a transducer which converts them into electrical signals. Similarly, Mechano transduction also has two components: the Mechano sensor, which senses the changes in the mechanical stimulus, and the Mechano transducer, which acts on these changes to produce the biochemical responses. So the Mechano sensors are multiple, belonging to several families of transmembrane proteins. However, they all converge on two main Mechano transducers called YAP and TAS. So crudely, this is how it looks. There are multiple mechanosensors which react to multiple stimulus. However, they all converge on two main mechanotransducers, YAP and TAS. So irrespective of the stimuli or the sensor. So we thought that this would be a good starting point for our study. So one robust way to answer such complex biological questions is to provide interlocking evidence with in vitro cell culture, animal and human data. So we studied the effect of deleting these two mechanotransducers, YAP and TAS, both in vivo and in vitro systems. So first, in cell culture systems, when we knocked down using siRNAs, we learned that the deletion YAP and TAS reduced RPE viability. So we learned that both these proteins are required for survival of the RPE. So the next is when we knock down these two, they induced RP inflammation. The expression of NLRP3, which is a very specific inflammatory agent in AMD, was increased. So this told us that YAP and TAS knockdown plays a specific role in macular degeneration. So though these findings were encouraging, we wanted to learn what happens actually in a living system. So we knocked down the expression of these two proteins in mice. So W2 are wild type mice where the expression of YAP and TAS is normal in the RPE, and these are double knockout mice where YAP and TAS is deleted only in the RPE. So on fundus photography of these mice, we see that the mice where the YAP and TAS was deleted, there was RPE degeneration as evidenced by this local area of hypopigmentation compared to the normal mice. Again on OCT, the YAP and TAS double knockout mice showed RPE loss and secondary photoreceptor degeneration compared to the normal mice. Again, we then started to study the RPE morphology. So this we used immunofluorescence staining of zonula occludens, which is a cell membrane protein where the RPE morphology is highlighted. So these are normal mice, and these are mice in which the deleted we can see that the RPE morphology is distorted. And this morphology was similar to the AMD RPE morphology seen in AMD. Interestingly, these mice also showed features of choroidal neovascularization on fluorescent angiography. So from the animal data, we learned that knockdown of YAP and TAS induced both wet and dry AMD phenotypes in mice. This is the first animal model to recapture both AMD phenotypes in mice. So again, encouraged by both cell culture and animal, we actually studied does it matter in humans. So we then measured the expression of these two proteins in the RPE in donor eyes with AMD. As you can see here, YAP and TAS expression was significantly decreased in the RPE in human donor eyes in AMD with AMD compared to normal human donor eyes. So what makes it even more intriguing is that there is this rare human disease called Swainson's chorioretinal atrophy, which is characterized by chronic progressive loss of the RPE. And the recent studies have shown that the mutation in the Mechano transduction pathway actually drives this disease. So this is rare, there are only 100 individuals with this disease. We had the opportunity to examine a donor eye with Swainson's chorioretinal atrophy, and the eye with Swainson's atrophy had similar immunopathological features to the eye with geographic atrophy. So by using a gamut of in vitro and in vivo systems, we find that normal RPE extracellular matrix or basement membrane adhesion signaling is required to maintain homeostasis, and sub-RPE deposits disrupt this signaling, leading to RPE inflammation, degeneration, and neovascularization. So the past 3 decades of AMD research has been focused on identifying the biochemical components of the drusen, and they've identified a multitude of components, and targeting these individual components has been the dominant therapeutic strategy in AMD over the past 3 decades. But our results suggest that an alternative to this existing biochemical hypothesis, we suggest a mechanochemical hypothesis where irrespective of what gets deposited, just the mechanical effects of these deposits are sufficient to cause RPE degeneration and neovascularization. Thank you.
Presentation was good and path-breaking, but there are many questions.
Yes.
How did you estimate all these things? How did you photograph, and how did you do a fluorescein angiography in the mice?
So actually a spectralis, Heidelberg spectralis is sufficient to do an OCT, sir, in mice.
Okay.
It works very well. Only difference is intravenous injection is difficult, so we give an intraperitoneal injection of fluorescein. So the time is delayed.
And how did you estimate those 2 things which are affected more, YAP and SAP?
So we took for fluorescent angiography, fundus photo, and OCT for both mice, for both groups of mice, for wild type and YAP and TAS. So in human eyes, the way is we collected the RPE, and then we took the protein and the RNA, we isolated.
Where from did you collect the RPE?
In human donor eyes, sir.
Donor eyes. Okay. Right.
So we do OCT of the donor eyes also.
Right. Do you think, like between the chicken and the hen and the egg, what should be happening first? Whether there is cell dysfunction, accumulation of lipofuscin, and this cell swelling, and therefore this swelling of cell giving rise to these chemical transmitters, or
So the source of the sub-RP deposits, there are again 2 schools of thought. Either it's the RP itself, or is it coming from the choroid. Irrespective of where the deposits come from, we think that the deposits themselves are causing the disease. So,
So your hypothesis
No.
is that there is a change in the cell,
floor on which the cells sit.
yeah, on the sits, and
Yeah.
that therefore these chemical transmitters
Yes.
are released, and that's what they cause
Yes.
the new vascularization
Yes.
or RP atrophy.
Both. Yes.
How I understand this is that the signal which causes the deposits, that may itself cause the mechano transduction, issues.
It can be a vicious cycle also.
It can be. It may not be even without those deposits. Have you studied that even without those deposits, you have the same kind of features?
Yes.
We do get, isn't it?
Yes, and now we are trying to study the biomechanical properties of the Brooks membrane to see if there is any difference in.
So that will be interesting that we see these changes even without those drusen's in those eyes that we see so often. Anyways, great.
Thank you.
Good one.
Good one.
The next speaker is Punita Kumari Sodhi. Is she here? Okay, and her presentation will be optical coherence tomography angiography in diabetic retinopathy after pan-retinal photocoagulation.
Honorable Chairpersons and my dear friends,
And your time starts now.
I'm going to present on the optical coherence tomography angiography parameters in diabetic retinopathy following pan-retinal photocoagulation. Currently, pan-retinal photocoagulation is considered the standard form of treatment for severe non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. It converts the ischemic retina into anoxic one, reducing the drive for new vascularization, improves oxygenation, reduces the VEGF secretion, and the reduction in the VEGF secretion causes vascular occlusion and again impairment of more blood circulation. PRP also alters the blood-retinal barrier and ocular blood flow. So it is worth to study the parameters of foveal avascular zone and vascular density after doing PRP with use of OCTA. However, there are very few studies on the same. Our aim was to find optical coherence tomography angiography parameters in diabetic retinopathy after PRP and also study the changes in the visual functions due to this. The study was approved by Institutional Ethical Committee and informed consent was obtained from the participants. Done at Department of Ophthalmology, Guru Nanak Eye Center and Maulana Azad Medical College as a prospective interventional study in 30 subjects with 52 affected eyes in the age range of 40 to 70 years. The subjects with other significant ocular and systemic diseases and having media opacity and high refractive error and other form of treatment were excluded. The history and examination were done for various visual functions and only subjects having best corrected visual acuity of 6/60 were taken. The OCTA was done with NIDEC model Advanced 2 in 3mm into 3mm scan. The PRP was done in a standard format. Repeat measurement was done after 1.5 months of PRP. Primary outcome parameter was OCTA parameter in subjects of following PRP. And t-test was used to compare the pre and post PRP parameters. This shows the demographic and clinical profile with duration of diabetes mean 10 years, 17 had hypertension, mean blood sugar fasting 158 and postprandial 234. Mean distance best corrected visual acuity was 6/36, IOP was 17 and contrast sensitivity was 0.9. The left side table shows the hemorrhage in 4 quadrants, venous bleeding in 2 and IRMA in 1 that remained the same after PRP. There was reduction in the severe form of neovascularization after PRP. However, there was increase in the axillar blur and axillary scotoma. On the right side table, there is clinically significant macular edema reduced. Other OCT features improved. However, there was worsening of drill, that is more of the disorganized of the retinal layers was observed. We see the ocular parameters, the various visual functions deteriorated following PRP, including visual acuity, contrast sensitivity, color vision, and visual fields. There was a hypermetropic shift, and the intraocular pressure also rose. The left side shows the qualitative phase, which was enlarged and distorted one, in which it became more enlarged and distorted following PRP. This is how the NIDEC, we click on each layer and to get the vascular density in these. As in our study at 1.5 months, the phase area and perimeter that reduced and circularity increased, which is a good sign. However, vessel density reduced in all the 6 layers. Only few studies have been done in literature to study phase in diabetic retinopathy, the first 3 have only studied the FAS dimensions, but the next 3 have studied following PRP, and Mir Shahi and Lorozo, they found that FAS area was unchanged, whereas Kim found that it reduced at 12 months. We also find a reduction at 1.5 months. FAS perimeter and circularity were not studied by them. Vessel density had been also studied by these authors, and they found there was initial reduction in the vessel density and later increase. And they have explained, for example, in this Kim, there was reduction at 1 month of the vessel density in SCP and DCP, and whereas after the same set of subjects, when they were followed for 1 year, that increased. So they've explained it that there is reorganization of capillary flow from periphery towards macula. With other methods like Doppler reflection spectra methods, authors have found improved choroidal circulation in macular area following PRP. Visual acuity has been studied by these authors, and they found initial reduction and later increase. Even the subject with clinically significant macular edema had an improved visual acuity. For example, in Dikshit, they have found that in high-risk month, visual acuity decreased at 1 month, and later at 4 months, it increased. So we have concluded from this study that FAS area and perimeter reduces and circularity increased following PRP. The vessel density in all the 6 layers reduced. Our study is the only study where all the 6 layers have been studied because we have got the software in the NIDEC machine. The results may not be comparable because of difference in age, race, equipment used, and period of follow-up. And we feel if we monitor these parameters, then we can find out what is the affection of the visual function in these subjects, and we can give them an idea of visual function affection increasing color vision and contrast sensitivity. And we can also tailor the treatment that instead of doing more and more laser and fill in PRP, we can go for alternative methods like anti-VEGF if these FAS and vessel density parameters are affected more adversely. Thank you.
Shall I ask? Yeah. See, the one thing which I probably don't agree to is that your laser therapy itself causes change in the vascularity. The increase, because you did not compare with the normal subjects.
Your normal subjects are there, last column.
Anyways,
Yes.
so what I found out, see, your increased vascularity is because of diabetes.
No, this is not vascularity, this is vessel density, that is vascular supply of superficial capillary plexus, deep capillary plexus, outer retina choriocapillaries and choroid. So their supply is reduced when we compare with normal values. Even pre-PRP also it is lesser value, and post-PRP also it is even lesser.
In fact, that vessel density is one of the indicators of preclinical diabetic retinopathy.
Yes, that's true.
But what he said, I also would agree that I will not expect vessel density to increase after doing panretinal photocoagulation. However, there is one parameter on which there will be improvement. And maybe this, what you are saying is that the vessel density has increased.
No, it has reduced in our study, 1.5
No,
months.
post PRP vessel density has to increase.
No, there are other authors who have studied, they found that initially, if same set of patients are followed for 1 year, later on due to reorganization that increases. But if it is measured at 1 month, 2 months, 3 months, then it is found to be less.
So that I feel is because of the fact that OCTA measures the blood velocity in the blood vessels, and thereby it is an indirect assumption that the blood vessel density has increased. So because the blood flow must be increasing, because the blood flow is getting diverted towards the area from where it was taken away by PRP, that is
Reorganization is there.
Correct.
Thank you.
Okay.
And
Thank you.
second one was your mean blood sugar levels of all patients were quite high.
Yes.
So poor glycemic control will affect the parameters whether you do PRP or you
Yeah,
don't.
that baselines are also less than the normals.
Not a point in favor of your study. Thank you.
Okay, thank you, doctor. See, the next presenter is Dr. Pallavi Sinha. Since she's not a ratified member, so we will not evaluate her presentation.
Next speaker को ये बुलाने.
No, but she'll be allowed to present.
Yes.
And retinal vasculitis and intraocular inflammation after intravitreal injection of brolucizumab.
Good afternoon, everyone. My presentation is on retinal vasculitis and intraocular infection after intravitreal injection of broclizumab. Introduction. Neovascular age-related macular degeneration is one of the leading cause of the diminution of vision in old age. Its pathophysiology involves the formation of new blood vessels in choroid and the retinal layers. Anti-VEGF class 1 of the drugs are the frequently used to treat this condition, and the broclizumab is one of the newest drug in this block, recently approved by FDA. The recommended dosage of broclizumab is 6 milligram. That's 0.5 milliliter of the solution, that is 120 milligram in 1 milliliter. It is administered through the intravitreal route. It is advised to have 3 leading doses once per month in the affected eyes, and the dosing interval is 8 to 12 weeks thereafter as recommended. This is the picture of broclizumab. It is a single chain antibody fragment that inhibits all isoforms of VEGF-A. It's the smallest of this anti-VEGF antibodies. Rest of the pictures are showing all of these. Now, to our aim of the study, the aim of our study was to evaluate the features and outcomes of eyes with retinal vasculitis and intraocular inflammation after intravitreal injection of the broclizumab 6 milligram in 0.05 ml for the treatment of the neovascular age-related macular degeneration. Our study design was in retrospective case series. Study period was from December 20 to July 21. Place of study is in the Rio Realms. Ethical approval was taken from the Institutional Ethics Committee, and there was no financial interest for this study. Now, 15 eyes of 12 patients were reported who had taken broclizumab intravitreal injection. Age, gender, concomitant systemic and ocular disorders, ocular symptoms, and the most recent documented visual acuity noted. Anterior and the posterior segment findings were evaluated before and after intravitreal broclizumab administration, and available retinal images were analyzed for the retinal vasculitis with the help of indirect ophthalmoscopic evaluation, fundus photograph, and fundus fluorescent angiography. Data analyzed using frequency and descriptive statistics. Now, our inclusion criteria was those patients who gave consent and diagnosed cases of the neovascular ARMD and who had taken intravitreal injection of broclizumab. Exclusion, who had not given consent and who had not taken intravitreal broclizumab. Results. 49 of 10 patients with retinal vasculitis were reported after intravitreal broclizumab injection, and the mean age of the patients were around 75 years. Most patients shown ocular discomfort, floaters, blurred vision, and scotomas. Retinal vasculitis and intraocular inflammation were diagnosed at the mean time of 30 plus minus 5 days after broclizumab injection. 2 patients shown only signs of intraocular inflammation and retinal vasculitis. Later on, after 3 weeks follow-up, despite anterior segment findings were improved later. 1 eye shown occlusion of the large retinal arteries at the optic disc and branches proximal to fovea with the worst visual outcome. In 2 eyes, segmental retinal periarteritis, release breaks noted. Results. So out of 14, 7 eyes shown decline of 0.3 logmar of the visual acuity or mole Snell equivalent to 3 lines. And the final V after the mean follow-up 25 days were 0.883 logmar, that's around 6 by 42. Now, is the fundus photograph and the OCT findings showing vitritis in one of the patients enrolled for our study. He was given broclizumab injection for this choroidal neovascularization, and he has shown vitritis after the second injection, after the second broclizumab injection, after around 20 days. Now, discussion. Retinal vasculitis were diagnosed as late as 20 weeks, at late as 8 weeks after the first injection and 8 to 25 days after second one. So it's kind of earlier after the second injection. And the patient's own features of intraocular inflammation followed up for the retinal vasculitis. Other causes of uveitis or any other embolic origin of the retinal vascular occlusion were ruled out. Intravitreal broclizumab were contraindicated when there was an active intraocular inflammation. Steroids were used to treat this intraocular inflammation. Predominant increased incidence of intraocular in females is similar to our findings. That is studied in the Hawk and Harrier study. Incidence cannot be determined as the nationwide data regarding this injection is not available. Hawk and Harrier study, they have they assessed the safety and efficacy of the broclizumab intravitreal injection for the treatment of the neovascular ARMD in comparison with the aflibercept, and they found it was quite comparable to the aflibercept, and the retinal vasculitis and the retinal occlusion were seen to be increased risk in patients with receiving broclizumab in comparison with aflibercept. Our study demonstrates unusual complication of the retinal vasculitis and intraocular inflammation associated with this administration of the anti-VEGF broclizumab used in neovascular AMD, which can adversely affect the vision of the patient, and it may span from the peripheral vasculitis, variable occlusion of the large or small arteries, or both, and the perivenular abnormalities may involve arteries around optic nerve or macula, severely affecting the visual outcome of the patient. These are my references. Thank you.
Thank you, Doctor. We will not have a discussion with your paper, but it's an important information for all the retina specialists.
So do you think the inflammation was controlled after with your steroids?
Yes, sir. A mild inflammation was controlled.
Did you stop giving brolucizumab after the conduction of the study
Yes,
or
sir.
conclusion of the study?
Sorry, sir?
Did you stop injecting brolucizumab after this study was concluded?
Yes, sir. I mean, yes, sir, kind of. We prefer bevacizumab. Sorry, sir.
I'm just trying to find out whether once the study was concluded, did the same incidence continue? That's all. Because our observations differ. That's all. Nothing. Thank you.
Thank you, sir.
The next speaker is Dr. Priya Pradeep Kumar Shah. She is speaking on effect of anti-VEGF on micromorphometric parameters.
Are you there for Priya Pratiksha?
Yes.
Okay, so your paper will not be evaluated.
Huh?
Because she is not the author.
She is not Priya Shah?
No, sir, I'm Dr. Apurva. I'm
Okay,
one of
fine.
the co-authors.
Okay, fine. You can present, but no evaluation for you.
उसका भी evaluation नहीं करना है.
नहीं, उसका नहीं करना।
कुठे? करत का नाही present? Is the presenting author present here?
Yes, sir. She is present, but is she?
So why is she not presenting? Why? Generally, it is not allowed to change the speakers.
Yes, sir.
But if you are here, please present.
All right. That's perfect. Just.
So then it will be evaluated as well.
So good afternoon, everyone. I'll be presenting on effect of anti-VEGF treatment on micromorphic parameters in chronic CSC and pachychoroid neovasculopathy. So chronic CSC, gravitational tract with a stipple fluorescence and variable amount of SRF, as we can see in these pictures. So pachymetry, pachychoroid neovasculopathy, and it's referred as CSC-associated CNVM. In OCTA, in this picture, we can see a non-invasive visualization of lurking PNV and with the same sensitivity as FFA. So my objectives and methods, outcomes of the training chronic CSC and PNV with anti-VEGF injection in terms of visual acuity and OCT, NFAS, OCT, and OCTA parameters. So prospective interventional study in January 2020, June 2020, which are RIB approved, and we have used the BCVA as a logmark, FFA, ICG as baseline, OCT, OCTA baseline, and follow-up OCTs. SRF height is measured, SRF area on NFAS OCTA, flat irregular PET, that is FIPED, hypo and hyper fluorescence, and network on OCTA. So in both groups, the off-label intravitreal bevacizumab, that is IVB 1.25 milligrams, was injected at the baseline and for 6 months. And then we have started a PRN treatment for 6 months. So PRN regime and re-injection if the SRF height reduction is less than 100 microns. So the outcome studies were done at the end of 6 months. So the result in chronic CSC PNV are as follows. The number of eyes in chronic CSC are 30 eyes of 28 patients. In PNV, 30 eyes of 29 patients. And the mean age is 52.6 to PNV 59.4. And the p-value of male and female is less than 0.001 in both. So mean follow-up days in chronic CSC is 172.12 plus minus 35.7, and PNV it's 184.32 plus minus 2.182. So in chronic CSC, 13 eyes, and after mean duration of follow-up of 8.6 months, the SRF height reduced significantly from 213 and at the base to 43.5, and the SRF volume also reduced from 0.9 to 0.1 at final visit. So my conclusion is SRF area as a reliable parameter to monitor the quantum of fluid in PNV and chronic CSC as an SRF area reduction are in parallel to SRF height. Bevacizumab is an efficacious treatment option in chronic CSC, and significant improve in BCVA and reduction in fluid can be achieved in chronic CSC with fewer injections than needed in PNV. Thank you.
You're asking something?
Nothing in specific.
No, I wish to find out why do you find that the effectiveness of bevacizumab is different in PNV and CSC?
So mostly the SRF height is reduced, and the area of SRF is significantly reduced in chronic CSC than PNV, sir.
What is the mechanism of SRF in chronic CSC and PNV?
That's actually
Okay.
not the scope of study actually.
Good, thank you.
Okay, thank you.
Thank you.
Evaluation of retinal nerve fiber thickness in diabetics as an early predictor of retinal damage. Dr. Narayanan Balakrishnan.
Presenting author is Dr. Sanjana. Fine.
Presenting author is Dr. Sanjana Chilukuri. Oh, sorry.
Good.
Good afternoon, everyone. My topic is evaluation of retinal nerve fiber thickness in diabetics as an early predictor of retinal damage. Introduction. The number of people worldwide at risk of developing vision loss from diabetes is predicted to double over the next 30 years. So it's important to develop better means to identify, prevent and treat retinopathy in its earlier stages rather than to wait for the onset of vision-threatening lesions. On the basis of vascular changes, diabetic retinopathy is subdivided into an early non-proliferative and a more advanced proliferative stage. Non-proliferative diabetic retinopathy can affect visual function through two mechanisms, that is, an increase in intraretinal vascular permeability resulting in macular edema and variable degrees of intraretinal capillary closure resulting in macular ischemia. There is evidence suggesting that neuronal changes have an important role in the development of diabetic retinopathy, and that retinal degeneration may precede visible or vascular changes. Diabetes-associated RNFL loss develops before the onset of the vascular retinopathy, and since nerve fiber layer ischemic changes occur even before the visible vasculopathy changes, it is essential to screen for nerve fiber layer defects and ischemia prior to the vascular changes, as they may help in analyzing the visual impairment prior to retinopathy. Optical coherence tomography has been proposed as a powerful tool for retinal measurement, and it provides detailed information with a high resolution. It also allows the direct measurement of the RNFL thickness by in vivo visualization of the retina and RNFL. Our objective in this study is to prevent the vascular damage to the retina by evaluating the retinal nerve fiber layer in type 2 diabetics who do not have any retinopathy changes. Methods, this is a comparative study between the 30 diabetic patients without retinopathy and 30 healthy non-diabetic patients. Inclusion criteria and exclusion includes age from 30 to 65 years and diabetics without retinopathy, and exclusion with diabetic retinopathy changes, previous macular laser photocoagulation, previous intravitreal injections, and traction effect in the macular area, and refractive errors, retinal vein occlusion, hypertensive retinopathy. Sample size calculation, keeping an alpha error of 5% and aiming for statistical significance of 0.05, we have calculated the sample size and arrived at the above mentioned numbers. All participants provided an informed consent before enrolling in the study, and the complete ophthalmological examination was performed. OCT imaging has been done using the Heidelberg Spectralis, and RNFL scan protocol was used to measure the peripapillary RNFL, producing a circular scan manually positioned at the optical disc center with circle diameter of 12 degrees. RNFL thickness was measured and reported as an overall mean, that is global, and by quadrants, whereby quantitative maps of the retina were obtained. Macular scan was also performed to exclude any macular edema. Results, the mean RNFL thickness in the superior, inferior, nasal and temporal quadrants were 119.2, 120.1, 80.6 and 63.2 respectively. The mean thickness was noted in each group in each of the quadrants and was found to be lesser than that of the control population. It is known that the temporal quadrant is thinnest and inferior the thickest, but however in our study there was significant thinning in the study population in the inferior and temporal quadrant. The analyzed data was ranked, and the sum of the ranks were done using the Mann-Whitney test, and the data was analyzed in each of the quadrants. Here in the table we can see that there is a inferior and temporal significant thinning, as in the tables. Discussion, we found that the RNFL thickness in the diabetic population was thinner in all the quadrants as compared to the non-diabetic population. Here the RNFL thickness in the inferior and the temporal quadrants was significantly thinner than the control population. Paul et al. Used HRA-OCT spectralis machine to assess the RNFL in patients with type 2 diabetes and reported that most of the patients with RNFL thinning had temporal quadrant lesions. This is similar to our study. But we also found thinning in the inferior quadrant, which is known to be the thickest of all the quadrants, and hence these results are of more clinical significance. In a study by Mohammed et al., where the study designs were very similar to ours, they analyzed the RNFL thickness in the various quadrants of the retina in diabetic patients with NPDR and without NPDR and non-diabetic patients, and found that RNFL thinning was more significant in the superior and inferior quadrants. These results were different from ours, where we found that there was thinning was more significant in the inferior and the temporal quadrants. The possibility of these results could be because the inferior quadrant is the thickest, and the changes occurring in this area may be the most sensitive to vascular changes when subjected to clinical analysis. Limitations of our study was the small sample size, therefore the results cannot be extrapolated to a larger population, and changes occurring at the RNFL in the OCT may be confounded by age. Conclusion, this study concludes that the RNFL thinning occurs in diabetic patients and may be an early sign of diabetic retinal damage even prior to the vascular damage. The imaging of retinal nerve fiber layer may be an important tool in assessing the diabetes related changes early, and should be made part of diabetic screening. Thank you.
Thank you.
Thank you.
Two things you could have correlated it with the duration of diabetes.
Yes.
Because if RNFL thinning was noted in patients who had diabetes of 5 years, and significant, even that RNFL thinning increased at 10 years of duration of diabetes. One thing. Second thing is, you did not mention anything about any subjecting these patients to investigations of glaucoma, because
IOP has been measured and the fundus examination has been taken for these patients, sir. There were no patients with glaucoma in the study.
There is a possibility of bias of confounders actually.
Yes.
So there could be many confounding factors which can affect RNFL, in non-diabetics as well as in diabetics also.
And at least an angiography was indicated in all these patients to compare it with a standard format which said that there was no retinopathy change. Means we are trying to say that even earlier than the fundus picture of diabetic retinopathy, these changes are appearing. How do we confirm that there are no fundus changes? First is by direct visualization of the fundus, and second by doing some invasive test which has an established role. So fundus fluorescein angiography had you done and said that we did FFA and there were no microaneurysms. There was no change in the vessel caliber. Then perhaps, but anyway, good.
Thank you.
Thank you.
Thank you, doctor.
Shruti Satpathy is going to present on OCT biomarkers and visual outcomes in the wet ARMD cases treated with intravitreal aflibercept.
She's not there. Okay, next one is?
Next, she's not there?
Satpathy is not there?
Absent. Last, diabetic macular edema in vitrectomized proliferative diabetic retinopathy eyes to treat or not. Umesh Chandra Behra.
Good afternoon, sir.
Good afternoon.
The macular-threatening tractional complications of proliferative diabetic retinopathy, when we treat with pars plana vitrectomy, it not only stabilizes the proliferative status of the diabetic retinopathy, but also improves the oxygenation of the eye and reduces the cytokine load in the vitreous cavity. And in this milieu, if it is coexisting with a diabetic macular edema, the macular edema also tends to resolve. But there could be surprises. Surprises even in those eyes which did not have any diabetic macular edema at the time of surgery, as in this particular case, where we do not see the evidence of diabetic macular edema, but when followed up for 6 months, there is an appearance of the macular edema. So how to manage it? We do not know the natural history of this kind of diabetic macular edema, which develop in vitrectomized eyes, which were treated for proliferative diabetic retinopathy. And the treatment for this DME in particular is not standardized. So to fill this knowledge gap, we tried to audit our own cases, which were operated between 2014 to 2019 at our hospital. The study was approved by the IRB, and the study, which was retrospective, followed the tenets of the Declaration of Helsinki. So all those cases which had documented evidence of diabetic macular edema following vitrectomy were included in the study. And also those eyes which had a persistent diabetic macular edema for at least 6 months following vitrectomy were included. So what we excluded were the eyes which had gross fibrovascular proliferation lifting the macula, that is macular traction. The eyes which did not have OCT documentations either pre-op or at particular points post-operatively. The eyes which were treated with silicone oil or had multiple VR interventions, eyes which developed macula holes and those eyes which did not have a follow-up of at least 1 year after the baseline. So we curated 56 eyes out of 1,039 records, and if we see, it's a very small fraction of the eyes which developed diabetic macular edema following vitrectomy. And with the inclusion and exclusion criteria, we settled with just 36 patients. So these eyes, when operated, were followed up every 3 months, and at the end of 6 months, if these eyes were detected with vision loss or diabetic macular edema more than 250 microns, they were offered with treatment, informing the patients that we do not have evidence on the efficacy of the treatment. So few of the patients would agree. As we see on the left hand side, the patient agreed for intravitreal injection, and when followed up at 9 months, although there was a reduction in height of the CST, the vision remained the same. So what about the other side? The other patient did not agree for a treatment, and when we followed up at 9 months, the macular edema had worsened. So we grouped these two kind of treatments, the one which received treatment in group A and which did not receive any treatment in group B. And all these groups were followed up for at least 1 year. The study followed all the standard statistical analysis for comparing the continuous and categorical variables. The strength of association between the two variables were represented by odds ratio and 95% confidence interval. The p-value was set at 0.05. So if we look at the intra-group effect of the treatment, when treated with anti-VEGF injections, the CST improved. The same improvement also was seen in those eyes which were not treated. But even after treatment, the visual acuity improvement was not significant in group A. So this could be because of the small number of cases that we had. But surprisingly, the group B, which had no treatment, had shown an improvement in vision. So these patients were followed up quite handsomely, like nearly 2.5 years or 3 years. If you look at the intergroup comparison, there were variables like the eyes which had systemic involvement, they were significantly more in group A. The preoperative PRP was done more often in the observed group. The baseline central subfield thickness was more in group A, and the diffuse nature of the edema was more so in the group. When we compared the post-operative parameters, most of them were comparable, both the central subfield thickness and the vision. So the key defining elements of this study was that this kind of complication is seen in a very small fraction of eyes when treated with parsippany vitrectomy. And although there is a continual morphological improvement, at the end of the 1 year or 2 years, there may be a persistent cystoid macular edema or sensory macular detachment if they are just followed up. So to conclude, vitrectomized eyes are already, since they are already in a reduced state of cytokine load, they may be just observed than being treated immediately. Since the follow-up for this study was 1 year, we do not recommend treatment for at least 1 year.
What do you think the mechanism of cystoid macular edema in post-vitrectomized eyes?
Thank you for the great question, sir. When we looked at the patients who were presenting to us after the analysis of this study, we would find that either the renal parameters would be deranged or the blood sugar would be deranged. But since it was a retrospective study, we didn't have any clue what had led to the reappearance of macular edema.
Were these cases were combined surgeries or only vitrectomy was done?
They were
Anterior
only
plus
vitrectomy. Vitrectomized, and none of them received silicone oil. It was just a fluid exchange after the surgery.
Why do you think that on OCT, the diabetic macular edema remained after removing the traction?
If we look at the edema following epithelial membrane removal, the mean time of resolution of that edema is 8 months. So in this study, or as a protocol in our hospital, we do not offer treatment for at least 6 months.
No, that's fine. But why do you think it remained?
Because the tissue remodeling takes time.
I feel that there are just two components, maybe whether you agree or not. Even when you see, obviously, how do you see that there is macular traction? On OCT.
Yeah.
But there is one more thing to it. In case the edema is focal, and the difference is much more as compared to LC, then we can say that it is only because of the traction. But if it is diffuse macular edema with some rise in focal areas, then you can say that both the mechanisms are acting. So I thought that in case it is not resolving early, it may be that there was a presence of diabetic macular edema and traction also added to that.
Yes.
You relieved the traction, but the diabetic retinopathy mechanism kept acting, and therefore that diabetic macular edema remained. Second thing is, once there is disorganization of the elements, no matter what you do, there would not be any improvement in vision.
Usually,
We thought that you would, at LVPI, they are quite good in formulating the parameters of the study.
The groups, I believe, I don't know how you made a comparison, pre-operative findings of patients and, in both the group, how could you, keep them similar?
It
That
not
was
similar.
and
There are
the
a lot
second
of parameters which were
that is point one. Second, which I thought maybe you are not the only person operating, so it's a operator dependent outcome as well.
Of course, yes.
And then, as you mentioned, as in your slides, that the pre-operative laser has an effect. So even the laser during the surgery may have the same effect. So basically, it may depend upon the surgeon. You may find out the surgeon as well.
And the duration of time when it was noted and the patient was subjected to surgery is an important parameter.
yes.
But anyway, it's a good study. We are happy.
We will actually
Thank you.
observe for a while.
Thank you.
Okay,
usually
thank
there
you.
are two parameters. One is
With that, we conclude-
continuous VEGF
with that
liberation.
we
despite
conclude
of
this
surgery.
session of free papers on
Second is-
diabetic retinopathy and medical retina. Thank you, Dr. Rajesh
Broken
Sahay
blood
and Dr.
retinal
Manoj
barrier.
Saswade.
Thank you, sir.
Thank you, presenters. They did a good job. Thank you.
सर सरांसोबत फोटो म्हणजे काय आनंदाची गोष्ट आहे
हाँ, मेरा नाम ही आनंद है, मैं क्या करूँ? एक मिनट, सीधा खड़े रह जा.
सीधा 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 yes
Thank you.
thank you very much चला प्रिया ओके डन व्हेरी वेल घेऊ ना मी बघितलं प्रियाला